I'll be talking about the soft tissue releases for forefoot ulcerations, specifically two procedures, plantar fasciotomy and peroneotomy. My name is Grace Craig. I'm from Cleveland, Ohio, and I'm in podiatry of Greater Cleveland practice. Diabetic patients have very challenging forefoot ulcerations, especially subhallux and subfirst metatarsal head ulcerations. They mostly heal with local wound carrots and offloading, including total contact casts. However, they all have very high reoccurrence rate of 60%. Here are a few pictures of subfirst metatarsal head ulceration and subhallux ulceration. Neuropathic patients have muscular imbalance due to the hypoglycemia. They have increase in plantar pressure, and some of them can develop cavus foot deformities where the patient can have contracted plantar fascia and plantar flex first metatarsal heads. It is important to optimize the patient with their nutritional status, their vasculature, by both ordering the ABI and the TBI. It is important to order the TBI because in Bunt et al.'s study, in his critical limb ischemic patients, majority of patients' ABIs were normal. It was the TBIs that actually show that the patients are having critical limb ischemia. And also for diabetic patients to optimize their hemoglobin A1C for the healing rate. With these procedures that I'm describing here, because of the minimal incisions that I'm making, you may be able to get away with a higher hemoglobin A1C. For plantar fasciotomy, it is for subhallux interphalangeal joint ulcerations. Here are some examples of the ulcerations. Some options of the subhallux ulcerations are tendal Achilles lengthening. With TAL, the healing rate is 85.7% to 100%. The reoccurrence rate is 0 to 41.7%. There is a temporary reduction of the peak forefoot pressure. However, approximately around 8 months, the plantar flexatory muscles eventually regain their strength as the deep compartments can also overcome and compensate for that lengthening. And one of the complications of the TAL is transfer lesion to the heel. Other options are IPJ arthroplasty and cheloarthroplasties. However, with these procedures, there's a 6.5% rate of transfer ulcers to adjacent metatarsal heads or lesser toes. There's a reoccurrence rate of 5.7%. And other complications due to the bigger incisions, there's wound dehiscence and infections. Now, with minimally invasive surgery, the complication may not apply. Hallux IPJ ulcerations has a component of hallux limitus with limited dorsiflexion of the first metatarsophalangeal joint. When there's also a tension of the plantar fascia, it reduces the hallux from dorsiflexing. Horton et al. Describe an in-stack plantar fasciotomy. When you perform that procedure, there's an increase in 9.8% dorsiflexion at the first metatarsophalangeal joint. Kim et al. In 2012 performed a plantar fascial release for various diabetic forefoot ulcerations. With Kim's results, there's no surgical site complications, no transfer lesions to the heel, and 0% reoccurrence rate. But Kim's success was only 60% of healing of all ulcers, and there's no distinct report of just the hallux IPJ healing. The plantar fascial release that was written by Chu et al. Shows that they have 100% success of healing of the ulceration subhallux. You hold the hallux in a dorsiflexion position in order to be able to identify the plantar fascia. Approximately 2 centimeters proximal to the tibial sesamoid is where you marked out where the incision will be medial to the plantar fascia. You inject the local anesthesia just 1 centimeter proximal to that. Therefore, the injection does not cloud where your incision is going to be, and it's easier to palpate the plantar fascia. You insert an 18-gauge needle to medial aspect of the plantar fascia where you marked it out. Once you insert it, you want to be careful of the flexor hallucis longus tendon. Then you make multiple sweeps in the coronal plane while dorsiflexing the hallux in order to tighten the plantar fascia. And you kind of palpate the plantar fascia with your thumb as shown. When you make the sweeps, you want to transect a few fibers at a time while advancing a little bit deeper after each swipe. And it is important to note that there are superficial plantar fascial fibers attaching to the skin. So when you make the incisions of those, make sure not to puncture through the skin and to make sure to also get those in your sweeps. Once you release the plantar fascia, you'll be able to palpate the defect. And there should be minimal bleeding because you're not violating any muscle bellies, so the flexor hallucis brevis and the abductor hallucis brevis muscles are intact. So hemostasis will be easily achieved just with compression. You then dress the incision with gauze, Kerlix, and Coban. Patient is able to weight bear right away with surgical shoe, and if you have offloading of the hallux, you can also wear regular shoes. The healing time for these ulcers are approximately 4 weeks to 13 weeks. For this procedure, it's important to know if there's any hallux IPGA sesamoids because that can impede the healing of the ulceration also. Some of the complication with this is a transfer ulcer to the second toe, but you can address that if the toe is flexible with a flexor tenotomy of the second digit. The next procedure is perineal tenotomy, and these are for ulcerations sub first metatarsal head. The theory for sub first metatarsal head ulceration is due to the imbalance of three extrinsic muscles: the extensor hallucis longus, the flexor hallucis longus, and the peroneus longus. And there's also some intrinsic muscle weaknesses. So the theory for first metatarsal head ulceration is that in a cavus foot, when the ankle is in a plantar flex position, the peroneus longus muscle gains advantage. And when the peroneus longus muscle gains advantage, it can pull more over-pull due to the weakness of Achilles tendon and therefore loading the first ray more. The peroneus longus tendon arises from 2/3 of the lateral fibula and it courses underneath the cuboid along the cuboid tunnel and attaches to the base of the first metatarsal and also the medial cuneiform. The function of the peroneus longus is that during propulsion, it stabilizes the first ray against the ground when the foot pivots over the first metatarsal phalangeal joint. Also, when during gait at mid to late mid stance, the talus dorsiflexes with the ankle mortise. As it dorsiflexes with the ankle mortise, it translates the fibula superiorly, laterally, and posteriorly. So when the fibula translates superiorly, it pulls the origin of the peroneus along with it. When the peroneus longus tendon is tightened, it then pulls on the base of the metatarsal and everts the cuboid. Therefore, then it stabilizes the first metatarsal head against the ground so the foot can roll over the first metatarsal phalangeal joint into propulsion. So what happens when you have these ulceration at the first metatarsal head? Some of the options are tendal Achilles lengthening, dorsiflexatory of the base of the first metatarsal, and lengthening of the peroneus longus. However, with all three of these procedures, it requires prolonged immobilization. Thomas Ruckus described in a procedure of peroneus longus tenotomy where you perform this procedure on the middle 1/3 of the peroneus longus. You make an incision, you deepen through the fascia, you isolate the peroneus longus tendon overlying the muscle belly, and you cut the tendon there. Therefore, by lengthening the peroneus longus tendon. With this procedure, it is done just distally or just proximally to the lateral malleolus, where you make the incision approximately 3 to 4 centimeters long, And if you can get away with it, you can make 2 centimeter incision, which might be a little bit difficult. You make the incision deep through the fascia, and then you isolate the peroneus longus tendon. You want to confirm it's the peroneus longus tendon, which is usually the first tendon that you see, by plantar flexing and dorsiflexing the first metatarsal. After the tenotomy, you close it just as you can close it with DEEP, but usually just skin, and you dress it with gauze, Kerlix, and Coban. The patient can weight bear on surgical shoe or regular shoe, and the healing time is approximately 4 to 12 weeks. So here's a picture showing before and after the procedure where the ulceration healed. You can see that there's a little bit more prominence of the first metatarsal on the left picture, and the left is a little bit more dorsiflexed. Here's another picture. I do not have the before, but you can see the first metatarsal head where the ulceration was, and the lateral ankle where the incision was. Here I'm showing a patient with a partial first ray amputation. I'm showing that I'm also incorporating this procedure in either hallux amputation at the first metatarsophalangeal joint or partial first ray amputations. The reason is because after amputating the hallux, the extrinsics of the flexor hallucis longus and the extensor hallucis longus are lost. Therefore, it's easier to have a plantar flexed first ray. And when you have that, it can become rigid, and where you can get an ulceration at wherever you amputate. So you see a lot of rigidity and new ulceration at the first metatarsal head, or more proximal where you amputate at the first metatarsal. Here's another picture showing partial first ray amputation where I incorporated the peroneus longus tenotomy, and you can see that there's already a plantar flexed first metatarsal. So after tenotomy and after postoperatively, over time, the first ray will actually dorsiflex with weight bearing. It is important to know if the first ray is flexible, semi-rigid, or rigid. When you have a rigid plantar flex first ray with this procedure, it might not work. Therefore, then you'll have to perform more of an osseous procedure. And when there's also severe equinus and there's a lot of forefoot loading, the procedure may also not work, and you'll have to perform a TAL or a gastrocnemius recession. You can actually do this procedure in the office if your office has the capability of it. Some of the complication of this procedure is that you can have a transfer lesion to the second metatarsal head. Sometimes you might have to address that with a floating metatarsal osteotomy, and there may be midfoot instability due to losing the peroneus longus to both the base of the first metatarsal and the medial cuneiform. Thank you.